Recording in progress.
Yes. Good evening, everyone. I am Dr. Amit Gupta, and I am the Joint Secretary of Diabetes India. And it is my proud privilege to welcome you all for this very, very important session that is a snapshot of the ADA, and we are on day 2. Yesterday, we discussed a lot of new advances which were discussed at the ADA, and almost more than 1,500 delegates they joined us live from different parts of the country. And today is the day 2, and we have a very eminent panel with us. We have Dr. Shashank Joshi, Dr. Ajay Tiwari, and Dr. Sanjay Agrawal, along with my co-chair, Dr. Manoj Chawla. So I would like Yogesh, please, can you please show me the introduction slide of Dr. Shashank Joshi? Dr. Shashank Joshi, as you all know, he is one of the most prominent endocrinologists of the country, and he has been the president of the almost each and every society of the India, including the API and the Dean, and he is the past chair of the IDA of Southeast Asia. And Dr. Shashank Joshi, sir, can you go to the slide of Dr. Shashank Joshi, which is the second slide in this case? Yogesh, slide number 4, please. So, Shashank Joshi, sir, you were at the ADA, and this program is specifically designed, keeping in that mind that all those faculties from India or the people who have attended the ADA, what they absorb from the ADA, they bring so many real-time insights, and these insights may be very, very useful for our Indian colleagues. Yogesh, you are showing the wrong slide. I have requested you to show the slide number 4, which is of Dr. Shashank Joshi. So, sir, this program, as I was mentioning, keeps only those chairperson as well as the faculty who were present at the ADA themselves. So, idea is to bring some real-world insights into diabetes, and you can actually bring the vibes of the ADA back to India. That what exactly was happening in at the ADA. So, for the brief introduction of Dr. Shashank Joshi, as I already mentioned, so one of the more notable achievement is that he is Padam Shri awarded by the Government of India in 2014, and multiple awards to his credits. So I will request Dr. Shashank Joshi, sir, to begin his talk, to begin his discussion today. And he is going to talk about the newer advances in incretin therapy. And we have, for the last 3 years, we have moved from a single agonist, then dual, then triple, and now we are talking about the quadruple agonist. So, sir, it would be great to hear from you that what are the latest advances and how this field is moving in for the management of the obesity. So over to you, sir. Yogesh, you stop sharing the screen. You allow Dr. Shashank Joshi, sir, to share his screen.
So at the onset, I would like to thank Diabetes India and Dr. Amit Gupta, Dr. Manoj Chawla, and everybody, Dr. Ajay Tiwari, for allowing me to talk on the next generation of therapies in type 2 diabetes and obesity, a snapshot from ADA. Because we are all being hearing single agent, dual agent, but there are a lot of novel agents which have come in this entire incretin space, injectable and oral, in obesity and type 2 diabetes. I'm going to allude to in the next 15-20 minutes on glucagon antagonist, which means we block glucagon, GLP-1 and glucagon agonist, amylin receptor agonist, and GIP agonist and GIP antagonist. So, when we are looking at fundamentally what we understood first were monoagonists, which means we just stimulate the GLP-1 receptor agent. And in that we had oral semaglutide, which is available in India. Then we have long-acting subcutaneous once-a-week agents like injectable semaglutide, which is now available in India, injection dulaglutide, which is now available in India. That is once in a week. Then we have injection liraglutide, which is once a day. And then we had short-acting subcutaneous agents before, like lixisenatide and exenatide. Then, we also have combined GLP-1 receptor agents and glucagon receptor agonists. So this is dual agonism. And there in that space, we have cotatudide and SAR 425689. Data both was presented at ADA phase 2, phase 3. Then, of course, we have the GLP-1 receptor agonism with GLP-1 receptor agonism, GIP-1 receptor agonism, which is a dual agent, which we all know is tirzepatide available in India now. And we also have the triple agent, which is LY37943 and SAR441255. All these agents fundamentally dock on the either GIP-1 receptor or GLP-1 receptor and do heterodimerization and internalization of the receptors. The one thing which was presented at ADA was a novel agent called glucagon antagonist, which means they bind to GIP on the adipose tissue explants and cell lines. They stimulate the insulin action and glucose uptake in adipose tissue. They increase the free fatty acid uptake and decrease lipolysis. So fundamentally, the agent of glucagon antagonist presented at ADA this year was called voglagidimab. These are like monoclonal antibodies. They have few side effects, low hypoglycemia risk, low fasting glucose, reducing the A1C. They had some liver issues on transaminase elimination, some lipid issues, and some weight gain issues. So fundamentally, that is something which was there. And these glucagon receptor antagonists, when they are combined with the SGLT2 inhibitor, they may have a very unique role in type 1 diabetes. We all know that SGLT2 inhibitors also had an adjuvant role, particularly dapagliflozin, in type 1 diabetes. In Europe, it had approval. But the only challenge with SGLT2 inhibitors in type 1 diabetes space is the incidence of euglycemic diabetic ketoacidosis. So at the ADA, this was presented by Schaffer et al., a randomized double-blind placebo-controlled crossover trial where they combined DAPA alone or in combination with vogladigamab 70 mg once a week in 12 adults with type 1 diabetes. And they were seeing not only improvement with this combination on glycemic control, but lesser dose of insulin and mitigating the risk of diabetic ketoacidosis. So fundamentally, what the glucagon antagonism was doing to the SGLT2 inhibitor in combination with a basal bolus therapy was reducing the total burden of insulin dose in a type 1 diabetic, better glycemic control, and elimination of diabetic ketoacidosis. So that was the first part. Glucagon antagonist combined efficiently with SGLT2 inhibitors and eliminating the risk of euglycemic diabetic ketoacidosis. A host of trials, phase 2, phase 3 programs were presented as GLP-1 and glucagon agonist, which means stimulation. In these dual agents, there were phase 2 and phase 3. Some of them were published in the journal of NEGM and Lancet Endocrinology. Mazaduotide once a week is a dual agent, which is very, very attractive. We will see that data from Innovent and Lilly. Then we have survodutide, which is once a week agent from BI stable, which made empagliflozin. Then we have pemvidutide, which is a once a week agent from Altimmune. Then we have epinephrine, which is a once a week agent from Merck Hanami. And then we have the AZ agent, AZD, once a week 9550. So this was mazaduotide, and this was a double-blind placebo-controlled trial from China by Lilongji et al. On obesity with or without diabetes, which is a GLP-1 and glucagon receptor dual agonist. And you could see that there is compelling weight loss, and with that compelling weight loss, there is compelling glucose control. So in Chinese population, the mazaduotide clearly showed in the phase 2 trial excellent A1C reduction with body weight reduction. So that was the first group of agent. Second is survodutide. In obesity, phase 2 trial program was presented at the ADA, and they showed that in all the tested doses of survodutide from BI, it was well tolerated, and dose dependently they were reducing body weight anywhere from 6.2% to 12.5% to 13.2% to 14.9%. So almost to the tune of 14.9% or 15% of weight loss. This is a subcute agent, 0.6, 2.4, 3.6, 4.8 milligram. And this data was available and was presented. Similar phase 2 data was also presented in the survodutide table by Julio Rosenberg and Buller et al. At the ADA, showing the impact on the diabetes control, and mild gastrointestinal side effects were observed. The other phase 2 trial was another agent called egnipeguduotide. And here you can see that there is a reduction in the BMI with A1C reduction, and the body weight changes were from 6.8% to 10% on a differential dosing scale. but a large proportion of these patients had nausea, vomiting, and diarrhea, and therefore it significantly reduced the body weight in a dose-dependent manner versus placebo, but the treatment emergent adverse events were quite large. So when we summarize various agents presented at ADA on weight loss and weight loss in type 2 diabetes, naturally the weight loss in type 2 diabetes is much lesser than the weight loss without diabetes. And mazatrutide, 4, 6, and 9 milligram, survodutide, pemvidutide, ephinoperidutide, semaglutide, tirzepatide, all this data was presented. And you can see the graphic here that sema and trazi have very compelling weight loss results without diabetes and have a little lesser reduction of weight loss with diabetes. So diabetes is a amplifier and a blunter of weight loss. Clearly, semaglutide, tirzepatide emerged as the blockbusters of the century, and 10 to 15% of weight loss was there, but the newer drugs are showing very promising results. So when we summarize all these agents, I think the A1C reduction standpoint, mazaduotide and survodutide is promising, but the egnopegadutide and pemvidutide are not so promising from an A1C perspective. When it comes to the mazaduotide and survodutide, in the obesity space, mazaduotide has GLORY 2, NCT, and GLORY OSA, which are ongoing trials in 25, 26, and 27 respectively. In the MASH space, liver space, we have 2 trials in the mazaduotide, including GLORY 3, 25 and 26 release, and the DREAM 3 for type 2 diabetes, which will be out by 26 February. In the survodutide table, there is a synchronized CN, 1, 2, and JP in the survodutide space from 25. And in the liver space, we have the leverage cirrhosis. And in the CVOT, we have the synchronized CVOT from the survodutide space. So this is the data which is there. The other class of agents which are presented at ADA were a myriad of agents which are basically amylin receptor agonists. You must have read in newspapers and internet and social media, the pramlintide was an old agent, but some data still getting churned out. But Novo Nordisk scientists innovated CagriSema, which is an amylin analog plus a GLP-1 analog once a week subcute for obesity and diabetes. That data was presented at ADA. Then AZT6234, an amylin analog once a week from Astra, was presented for obesity. The eloralintide is from Eli Lilly, amylin analog once a week. The petrilinetide is an amylin analog from Zealand Roche. The amicriptin, which is amylin with GLP-1 from Novo Nordisk, it's a GLP-1 mimic once a week. Then the Gubo, that is the Gubra 14295 is amylin analog from AbbVie. Amylin 355 is amylin analog from Novo Nordisk. Amylin 1213 is a amylin analog again from Novo Nordisk. And Metsera has their amylin analog as the MET 233I. These are all the agents which look very attractive from the amylin table. One of them is the cagrilinetide. And here you can see very, very compelling data presented at ADA again on the body weight change from baseline. And clearly that is something which is here to stay. So the next group is GIP agonism and GIP antagonism. When there is agonism, that is what we get tirzepatide. When there is antagonism, that is where the AM133 came from. This is paradoxical. How do you make sense of pushing and pulling to get the same place? Because when you pull and when you push, you are still getting the same biological impact, and that is the novelty of these products. Let us look at the data. Again, this was published in the New England Journal of Medicine on the direct head-to-head comparison of tirzepatide versus semaglutide, where tirzepatide scored over semaglutide in terms of weight loss. So when it came to really the AMG 133 on body weight, here you can see the GIP-1 receptor antagonist with GLP-1 receptor agonist. Okay, there is body weight reduction. And not only there is body weight reduction, but there is also glucose reduction. And they work conjugatedly for a differential impact. So finally, what did I tell you? Many combinations were presented at ADA. And one combination which I said is if you block the glucagon antagonist, voglagitamab, with SGLT2 inhibitor, if you use it with type 1 diabetes, you eliminate the risk of euglycemic decay. Work in progress, phase 2, phase 3 data, exciting data. Second is the GLP-1 glucagon agonists. Again, next generation therapy for holistic metabolic care. Robust weight loss up to 15 millimeters. Very good clearance of liver fat and cardiometabolic risk. And for obesity and type 2 diabetes, a Chinese molecule now available in China called mazaduotide and survodutide are undergoing trials for obesity and CVOT. Then the next class was amylin. Amylin has all types of permutations, combinations, including the caraglutide, cagrisema, with body weight loss as well as glucose loss. And finally, the GIP-1 receptor antagonist, because agonist we know with GLP-1 is tirzepatide. But if they're antagonist with GLP-1 analog, you get AMG 133, early stage trials with promising scope. So what I have tried to do is that we are looking at agents which are GIP-1 agonists and antagonists, but they're still producing same effects. We are looking at GIP-1 antagonists, which look promising, how they differ from antagonist, and how are these very differentially used. So ADA actually had this unique data set to the next generation. See, in the first generation, we only understood that there was a simple exenatide, simple liraglutide, or a lixisenatide. From there, we migrated to a simple single agent like a semaglutide, and with a snack in the oral space. From there, we migrated into GLP-1 and GIP-1 space, which is fundamentally the tirzepatide space. Then last year at ADA, we saw a lot of data on triple agent retatrutide. But this year, we saw unique combinations. GLP-1, GIP, same direction. GLP-1, GIP, opposite direction. GLP, glucagon antagonist. And we also saw amylin agents or analogs. So we saw entire permutations and combinations in this entire interesting incretin biology. So I just wanted to give you a glimpse, and there were posters, there were late breakers, and there were multiple sessions related to this. In fact, some of the sessions were so big, like the Kagri-Sema session, that we thought that we were entering the Banting lecture and we were standing in a line, and actually that line was for Kagri-Sema talk. So people were more interested in these molecules than the actual Banting lecture. So I think we are in exciting times. There is exciting data, and in times to come, you will have many of these agents available, including compassionate age.
Thank you, Shashank sir, for summing it up and giving such a large number of GLP-1, GIP-based therapies in such a short time and summing everything so nicely from the idea. Sir, one thing, as you rightly mentioned, so till now we are talking about the weight loss, and we know that the weight loss comes with some kind of muscle loss as well. But now in the ADA, we just heard a new one of the new molecules, which is going to affect only the weight, address only the adiposity and not the muscle, and is going to actually protect the muscle. So what is your take on that, sir?
So at ADA, we saw multiple agents. Amit, that's a very good question. So remember, any type of weight loss therapy, whether it's lifestyle or whether it's medicine or whether it is surgery, will cause fat loss and weight loss with muscle loss. The fat to muscle ratio is what counts. Now, you absolutely are right that at ADA, we saw selective fat loss agents where the muscle mass loss has been stopped. That is one. Second, we also saw agents which are purely improving sarcopenia, which means they are metabolic mitochondrial modulators. And there are companies which are now undergoing phase 2, phase 3 clinical trial program, which will just build up your muscle. So we will have one agent which causes selective fat loss. We'll have another agent which will cause selective fat loss and block the muscle mass loss. And we'll have also selective fat loss agents. Even if they cause muscle mass loss, we'll have agents which will improve their muscle strength and muscle biology. So all these permutation combinations are there. There are new companies which are marketing some of these molecules. These are all in their phase 2, phase 3 clinical trial programs. We are still a long way to go, but you never know. The agent for MASH, which is remestron, okay, is now available from Bhutan for compassionate use in India. So many of these agents, as Amit you are rightly saying, may come to India through a third-party route, and our population selectively may be having availability. One muscle loss point everybody should know as a clinician, that if you are above 65, And if you lose muscle loss, then you will increase mortality. So preserving muscle mass in a patient with borderline CKD or in the elderly population above 65 is crucial for saving their lives. Because if you are just going to get fat loss with lot of muscle mass loss, you will actually increase mortality. And therefore, in this vulnerable group of geriatric population above 65 or in the CKD group, preservation of muscle function and therapies which promote muscle mass and muscle strength will have a huge relevance. So that clear-cut clinical space, there is an unmet need, and these agents provide that gap.
Sir, one more question to you. So, out of all the molecules which you have just mentioned today, which molecule seems to be the most promising one, which you will be actually looking forward to?
So currently, I'm excited about retatrutide because it is competing with bariatric surgery. Okay, and so that I'm really excited about that molecule. Though that data was not presented at ADA. From the stable which I presented to you, I think surotatide and musatotide appear to be most attractive with CagriSema. All the three agents appear to be very good. Amylin is work in progress. We need to see more data in that space. And the GIP-1 antagonist also, we need to see more data in that space. So I would say in these two spaces, I will still wait for a year to see more data. But retatrutide, definitely I'm more excited. Suruo, we have now clear idea where it's going. And mazatrutide also, we have clear idea where it's going. So if as a clinician I have to write, I have 3 extra molecules on an occasional case to offer.
And
Amit,
sir,
can
one
I?
more point.
Sorry.
Yes, yes,
Go ahead.
please, please.
No. I thought I'll
Uh,
take this opportunity to thank Sashank for that wonderful talk. It was almost revisiting Chicago again with those
Yes.
Incretin talks that we were rushing for. A quick question, Shashank, how necessary you think it is for clinicians to start using body composition on a routine basis to monitor patients on the newer peptides? How useful and how necessary?
I think it is very necessary. I think, Manu, that's a great question. I think every patient, before you start this therapy, if you get a body composition analysis through whatever measure it is, you will get a baseline. And then maybe evaluating it every 6 months or 1 year, you will get a yardstick, how much of fat is lost, how much of muscle is lost. And it is also important to recognize that you should co-prescribe them strength training exercises and some muscle proteins and some biological modulators which will improve and preserve muscle mass function. So I think that's a very, very good point, Manoj, which you make. And also it is important, the reason why we need it, why Manoj made this point of body composition is because then we'll know the muscle to fat ratio. So even if you don't get the absolute values, many people say we have, say, a machine like a InBody or something, which is not very accurate. The gym trainers, they also give you the body composition, which is based on the water content. But the ratios, if you see them altered, fat to muscle ratio, that is reasonably. Sometimes you know what happens when we measure body composition except DEXA, and DEXA is not possible for everybody, then we rely on some of these machines. These machines are water dependent. So if you do it different times of the day, it will be different. And therefore, for that standpoint, I think the muscle to fat ratio, if you calculate at the beginning of therapy, after 3 months, after 6 months, after 1 year, then Manoj, it will be a great thing. And that is the preservation of muscle to fat ratio is crucial. And therefore, strength training exercises and some muscle proteins are equally important as co-prescription. And therefore, I think you made a very valid point, and it's a very valuable clinical point.
Thank you. Thanks, Shashank.
Thank you, Shashank sir. If you are not late, I would just like to ask one more question. As you rightly highlighted that people with diabetes and obesity, so they tend to lose less weight in comparison to those only with obesity when we are using these anti-obesity agents. So I think this is another area which all people practicing diabetes should remember that people with diabetes are not, they may not exactly achieve the similar amount of weight loss which a person with only obesity and may achieve. Sir.
That's a great point. So that depends, Amit, on something called as nitrogen balance. And that is more applicable for Caucasian data. We are thin fat Indians. So, there is something called as an anabolic switch and a catabolic switch. So, what happens is that when a person is coming with uncontrolled diabetes, he has already lost weight. And then when we are trying to get their glucose under control, they regain that lost weight. Okay. When we are doing agents like a single, dual, or a triple agent, and we are right now only doing single and dual, what is happening is we are initiating weight loss. When we are initiating weight loss, it is important, as Manoj said, to know not only the body composition for fat to muscle, but it's important to know what is the nitrogen state of that person. Is it into a negative nitrogen balance? Is it into a positive nitrogen balance? Is it into the anabolic space or is it into the catabolic space? Or is it in the eubolic space? And we should travel. You have very correctly asked this question that we should try to travel in the eubolic space, particularly if you are having type 2 diabetes. Because in type 2 diabetes, it is very relevant because type 2 diabetes is a blunter of the weight loss. In absence of type 2 diabetes, with only cardiovascular disease, say somebody has a heart attack or a revascularization with obesity, then that weight loss is more compelling. So actually diabetes eats out that area under the curve for weight loss. And therefore, in that also you need to use the eubolic nitrogen model to understand anabolic space and catabolic space. I hope I am very clear.
Thank you, sir. I can see Bansi sir also, he has joined now. And Dr. Manoj Chawla is
And
there.
in between, I
Yes.
joined one more meeting. So I'm
Yeah, we are
sorry,
all.
Amit, and
I am
you
not there. I think I missed
No,
it.
no.
There. I had to go there.
So,
wonderful
Bansi
talk,
sir,
and we
Manoj
will
sir,
learn more from
Yeah.
Shashank. Sanjay will
Um,
join little later, so we can invite Ajay first for this
yes.
talk.
Thank
Thank
you.
you, Shashank, for wonderful talk. Thank you.
So the next talk is by Dr.
Dr. Ajay
Brij Mohan, by Dr.
Tiwari.
Dr. Ajay Tiwari is taking that talk. Okay, excellent.
No,
So,
no, Shashank, Sanjay will talk the last. He is joining in next 15 minutes.
right. So the talk on FC Tora has been taken by Dr. Ajay Tiwari.
Yes.
Right. So that gives us great pleasure to invite Dr. Ajay Tiwari, senior physician from Lucknow, who will be speaking to us on the newer insulin, which is FC Tora. So some great amount of data and its phase 3 program data was shared at Chicago at ADA. And it give me great pleasure to invite Dr. Ajay Tiwari to share their data and thoughts on FC Tora. Over to you, Dr. Ajay Tiwari. Looking forward to your talk and then the discussion after that.
Thank you, Manoj sir. And at the onset, I'd like to thank Diabetes India and especially Banshi Sabu sir and Amit Gupta brother for giving me this opportunity. And I think this is a very interesting topic because we have been being exposed at international meetings to once weekly insulins. So this particular insulin, this is a once weekly insulin from Eli Lilly. We already know that we already have one insulin which has already been cleared in European and Canadian markets. That is the ICODAC by Novo Nordisk. So a very comprehensive program, that is the Quint trial program, was presented at ADA. And just to give basics why we intend to have more insulins and easy insulins which can be given once a week. So I'll be just giving a brief overview. So this is the NHANS data, and they've seen that only 29% of the people are on insulin, and of the people who are on insulin, around 38% people are maintaining A1C of more than 8%, less than 8%, 62%, and less than 7%, only 34%. So definitely we have a problem with initiation and intensification of the insulin. And this is a word about the basics, and this is all across the world. If you see the data, that still after initiation of basal insulin, the intensification part is lacking, and at 3 months, only 21% of the people could achieve an A1C of less than 7%, and at 12 months, only 28%. So the figures are very dismal, and we all know that the basic reason for the non-adherence is that despite of the best efforts, 33% of the patients report missing, omitting insulin at least once a month, average 3.3 days per month. And we all are aware about the reasons for that, because we have a busy lifestyle, traveling, skipping meals, and all those things are there. Embarrassing to inject in public. So we have some data, and we have seen that we have been using a lot of GLP-1 analogs on a weekly basis. So what we have seen that if we are using a weekly formulation as compared to a daily GLP analog, we have a better adherence, and at the same time we also have a slightly better glycemic control, because that may be because of better adherence to the regimens. So this is a data from, because we do not have a data primarily from a once weekly insulin as regards to adherence. So this is our data from other source. So potential impact of weekly insulin on barriers to effective insulin administration. So what we will gain out of this? The lack of time, lack of flexibility, and embarrassment to inject in a public place. So that could be mitigated. HCPs, if they do it properly, then time constraints, titration too complex for patient, lack of support. So all these things can be mitigated if we are going for a weekly insulin. So the basic need is initiation of insulin still often delayed. Clinical inertia is there both at the level of the physician and at the same time at the level of the patient. Basal insulin suboptimally implemented and titrated. Concerns regarding hypoglycemia and weight gain, fear of injections, poor treatment adherence, and poor treatment persistence. So we have two formulations with us that I have already told you. One is Fcitora alpha. That is a fusion protein that combines a single chain variant of insulin with a human IGC Fc domain. It has been developed by Eli Lilly and in phase 3 clinical development program, that is the QUINT program. And ICODAC, this is a novel basal insulin analog. So it's already been cleared by the European Medical Agency and the Canadian agency. So now comparing these two, this is just a background, what we are going basically to talk in the QUINT trials. So this is basically about the ICODAC and the Fcitora. So if you see that the Fcitora has a longer half-life as compared to the ICODAC. The ICODAC has 8 days half-life and it has got a 19 days half-life. And if you see, it has a very flatter profile as compared, the Fcitora has a more flatter profile as compared to the ICODAC. So this half-life of 19 days allows once weekly dosing, prolonged half-life due to slow absorption from subcutaneous space, FcRn mediated recycling reduces renal clearance. So this is the reason. So this is a very beautiful presentation of this. This is a novel single chain insulin variant and it is clubbed with a human Ig2 Fc domain. So the mechanism of action is reduced insulin receptor affinity, reduced receptor mediated clearance, large molecules 64.1 kilodalton. So reduced renal clearance. FcRn binding prolongs activity, prevents insulin degradation and recycling to cell surface. So this is a basic about what we are going to discuss today. That is the Fcitora. And if you see the PK at steady state, so you have a peak to trough ratio of 1.6 and a half-life of 19 days. And the maximum glucose lowering effect occurs at 4.5 days. Peak to trough ratio is 1.07 and the glucose lowering effect consistent over the week. So this was slightly different from ICODAC. We do not have a head-to-head trial with ICODAC, but if you see the PK-PD profile, so it has a more flatter and a lesser peak to trough ratio as compared to the ICODAC. So now coming to the phase 3 program, that is the QUINT once weekly insulin therapy. So we have 5 programs. So the QUINT 1 and QUINT 2 was in insulin naive patients. So the one was insulin naive fixed dose escalation with glargine. That was a 52-week program. Then insulin naive versus degludec. That is the 52-week program. Then there is a basal switch versus degludec. It was in type 2 diabetes. All these programs up to this QUINT 3 were QUINT 4 were in the type 2 diabetes patients. And basal plus mealtime insulin therapy, that is the type 2 diabetes with multiple daily injections versus glargine, that is the 52-week, and the type 2 diabetes doses injections versus degludec, that was in QUINT 5. So this is the basic presentation. So in the QUINT program overview, we have 5 phase 3 global registration studies, 4,000 plus participants enrolled, type 1 and type 2 diabetes population started in 2022, multi-center randomized open label design. So this is a brief overview of the 5 trials, and we will be discussing more the QUINT 3 and QUINT 4, which was presented at ADA. So the QUINT 1 was it was a 52-week open label treat to target design, and the population was 795 insulin naive type 2 diabetes agents. The comparator was insulin glargine U100, and the primary endpoint was non-inferiority in HbA1c reduction at week 52, and the unique feature fixed dose escalation regimen. Then the material and methods were inclusion was A1C between 7 to 10%, BMI less than 45, fixed dose 100, 150 to 50, 400 units weekly. Dose adjustments every 4 weeks. Targets of the fasting blood glucose was 80 to 130 milligram per DL. 1 to 3 non-insulin agents allowed. So what we found was the A1C reduction in the glargine HbA1c reduction was minus 1.27. In Ifsitora, it was 6.92 and 40% lower hypoglycemic risk in Ifsitora. Non-inferiority achieved with significantly fewer dose adjustments, median 2 versus 8, and lower hypoglycemia rates 0.50 versus 0.88 events per patient year. Then coming to the QUINT2, that is the insulin naive type 2 diabetes patients with flexible dosing. This was a 52-week parallel treat to target population 928 insulin naive type 2 diabetes patients, and the comparator was insulin degludec U200, and the primary endpoint was non-inferiority in A1C at week 52. Flexible weekly titration, same set of material and methods. A1C reduction with Ifsitora was minus 1.34. With degludec, it was minus 1.26. Time in range, because they had CGM, mass CGM data also. So we had 64.3% time in range with Ifsitora, and this was plus 45-minute time in range. The key result was non-inferiority achieved with superior time in range and effectiveness regardless of concurrent GLP-RA use. No severe hypoglycemia with Ifsitora versus 6 episodes with degludec. So these were the 3 trials, and these QUINT3 and QUINT4 will be discussing in great detail. So this is just a snapshot. So again, it was an insulin degludec U100 comparator trial. And then primary endpoint was they just wanted to show non-inferiority at 0.4% in A1C at week 26. And the randomization was 2:1 Ifsitora versus degludec. 3-week lead-in period, 5-week safety follow-up, flexible dosing algorithm, and the target FBG was 80 to 130 milligram per DL, and they allowed the continuation of the non-insulin agents. So this was what was achieved: 0.86% reduction with Ifsitora, 0.75% degludec, so non-inferior. Final A1C 6.93 in Ifsitora group, and 62.8% time in range with Ifsitora. So the key point was successful transition from daily to weekly insulin with non-inferior glycemic control and similar hypoglycemia rates, 0.84 versus 0.74 events per patient year. Then QUINT4 was basal bolus simplification. So we had a component of Lispro also added to the comparator, that was the insulin glargine plus Lispro. And this design was 26-week parallel treat to target. And the primary endpoint was non-inferiority in A1C at week 26. And the setting was multiple daily injections intensification. So more than 2 parenteral injections daily required, insulin Lispro for both groups, weekly versus daily basal insulin. And the target again was 80 to 130 milligram per DL, and the non-insulin agents were continued. So in around 1.07% reduction in both groups, A1C reduction. Final A1C in Ifsitora group was 7.12, and final A1C in glargine group was 7.11, and the hypoglycemia events per year were 0.58. So equivalent glycemic control with once weekly basal insulin in complex basal bolus regimens, demonstrating versatility across treatment intensification levels. So primarily we are talking about different scenarios. If you are shifting from once a daily basal insulin to a once weekly insulin, or we are having a complex regimen with multiple daily injections, we are talking about the active comparators like glargine and degludec. So this is all what it is all about. And this QUINT5 is basically for type 1 diabetes patients. So as was in the ICODAC, also the onward program, there were higher incidence of severe hypoglycemia was less, minus 10%, but there is a slightly increased numerical increase in the severe hypoglycemia incidence. And this was the reason why This icodec also could not get a US FDA clearance because there in the type 1 study, in the type 1 part of the onwards program, there was a higher incidence of hypoglycemia. So this was a session which happened in American Diabetes Association, and we had very eminent faculty which was presenting this program. So this was what I have already briefed you about the QUID program. This is a phase 3 trial, and these particularly the QUID 3 and QUID 4 was presented there, and thereafter there was a session as regards to why we should go for a weekly insulin, or is it practical or not. So we will have some great insights regarding this. So this was the presentation by Athena Phyllis, and she presented on long-term efficacy and safety of insulin Ifsitora as a weekly basal insulin compared to insulin degludec in participants with type 2 diabetes currently treated on basal insulin. So this was the program, and these were the countries which participated in this. So this, I've already given you a brief about this. So it was, the primary assessment was done at 26 weeks and the program was continued for 78 weeks. And there was a 5 weeks follow-up after the end of the treatment. So this is how they started with it. So Ifsitora week 1, first injection, 1 time starting dose, that is a daily basal dose in lead-in into 7 into 3. So that was a loading dose, the first dose in the week 1. The first dose, and from the week 2, the weekly dose was daily basal dose in lead-in plus into 7. So you see with the icodec also we do the same thing, the basal dose into 7, and same is here, but we have a loading dose concept for the first because it has got a very long half-life. So we have to give a loading dose that is 3 times this total of the daily basal dose into 7. Then degludec, it was 1-to-1 conversion from previous daily insulin, and this is the algorithm which was used. So depending upon the hypoglycemia or so how they were titrating, they were based on the median of 3 most recent FBGs in the previous week. So depending upon that, the median value, they were deciding to go upwards or downwards. And this was a regimen which was used to go with the dose titration. So the primary objective was non-inferiority and to demonstrate superiority of Ifsitora compared to degludec, and a change in A1C from baseline at week 26, and the event rate of participants reported combined nocturnal clinical. So they were basically looking for severe hypoglycemia, level 2 hypoglycemia, level 3 hypoglycemia, and they were also interested in seeing the time in glucose range, the CGM data, because they had a masked CGM compound part of this program. So this was the set of patients. So evenly matched and very few left outs. And this was basically the demographics of the participants. So it was evenly matched. And this was what they were already having, and the number of medications. Most of the patients were having 1 or 2 agents plus the basal insulin. So this was the breakup, and the breakup was almost similar in the 2 groups. Then this is the primary objective. So at week 26, with Ifsitora, we had reduction of 6.93. So the baseline A1C was 7.80 in both groups, and at week 26, it was 6.93% with Ifsitora and 7.03%. So they could show non-inferiority. And at week 78, it was 7.16 and 7.27. And the treatment regimen estimate change from the baseline A1C was 0.81 in the Ifsitora group and 0.72% in the degludec group. Then no significant difference in participants reporting combined nocturnal glycemic, clinically significant level 2 less than 54 or severe level 3 hypoglycemia. So it was similar. Numerically more in people with Ifsitora, but it was not statistically significant. Then patient reported outcomes. So they had a component of the satisfaction rate. So this DTSQ was given to them. And the patients on Ifsitora, they reported a greater satisfaction ratio because a lesser number of injections as compared to degludec. And then this is very interesting that the CGM data, because these studies were unique because they also had a mass CGM component. So you see that across both treatments, more than 2 hours were spent in range. More than 2 hours were spent in range at 26 weeks compared to the baseline. Then overview of adverse events, that was important, so it was comparable. Treatment-related adverse events were more in Ifsitora group, and that was attributable to because the treating HCPs did not have a clear idea as regards to the initiation and titration of this particular molecule. So there were these treatment-related adverse events. The rest of the things were similar in the two groups. Then fasting blood glucose, again you see at week 26, 118 and 1. So almost comparable data at both week 26 and week 78. Mean weekly basal insulin dose, so it was lower with Ifsitora as compared to Degludec. Then a very important point was change in body weight and BMI. So it was similar in both the groups. Then patient reported hypoglycemia because they were only focusing on this thing. So if you see, this is numerically more level 1 hypoglycemia with Ifsitora, but as regards to level 2 and level 3, it is almost similar, and there is no statistical difference between these two. Then this is the overview of adverse events we have already discussed. So basically, this is what the patients, because this is more about the ease of injection or the comfort or the adherence. So what the patient said, so this is one of the participants. So I am all for results lasting a full week without needing another shot made a difference for me. So that is the most important thing, the ease of injection and reducing the number of pricks. That is what all these weekly injections are trying to afford. I was able to better manage my numbers without having to think about it. Can't wait to have it approved. So this is the Lancet article, which was this Quint3 trial was published in the Lancet. Then coming to the Quint4 trial, so this is almost similar, and this was presented by Thomas C. Blevins. And this particular trial was interesting because it had some population contributing from India also, and similar sort of trial program, and it was for 26 weeks. The previous one was for 72 weeks. The estimates were taken at 26 weeks, but this is for 26 weeks. And after that, there was a 5 weeks follow-up. So this is how they did. Week 1, first injection, 1 time starting dose, daily basal dose in lead-in plus into 7 into 3. So that was the loading dose. And thereafter, they had gone for daily basal dose. That is lead-in into 7, and Glargine, it was 1-to-1 conversion. And this is the same regimen they followed as regards to the reduction, or if and that was based on the mean of the 3 fasting blood glucose levels. So the primary objective was similar. They wanted to show non-inferiority and the non-inferiority margin of 0.4%. And the secondary was to change in A1C from baseline at week 26 and the level of level 2, level 3, and the nocturnal hypoglycemia. So this was the distribution, the patient participant disposition. Similar baseline demographics, the clinical characteristics. Again, these patients were allowed to have all the glucose lowering agents, but they were not allowed to have sulfonylureas. All other agents were included in the study, and most of the patients were having 1 or 2 additional glucose lowering agents. So the primary objective at week 26, so it was A1C reduction from baseline of 8.18 came down to 7.12 in the Ifsitora group and 7.11 in the Glargine group. And A1C reduction at week 26, the treatment regimen estimate was minus 1.01 with Ifsitora and 1.00 with Glargine. Key secondary objective was no significant difference in percentage of participants achieving A1C less than 7 without nocturnal level of level 2 or 3 hypoglycemia. So it was comparable, 39.5 and 36.6. No significant difference in participant reported combined nocturnal clinically significant or severe level 3 hypoglycemia. So this is as regards to this, and it was less with Ifsitora as compared to Glargine. And the same story as regards to the CGM data, more than 4 more hours spent in range per day, with both of them at as compared to the baseline and week 22 and 26, at 10 more minutes spent below range per day. So that is something which was to be seen. And the fasting blood glucose, we are seeing the values as compared to the Ifsitora and Glargine, almost similar, 133 and 138. Then this is the requirement of insulin. So we had a bolus component in this, the Lispro. So again, we have lesser requirement for the this bolus injection with Ipsitora as compared to the Glargine component. Patient reported hypoglycemia, again almost similar, numerically higher in the level 1, but similar in level 2, 3, and nocturnal hypoglycemia. So these are the treatment related. So almost similar with the Quint 3. This is as regards to the patient reported outcomes, basal insulin experience questionnaire. So if you see in this dark blue line, it shows strong preference for the study insulin. So if you see Ipsitora versus Glargine, so they have a higher preference for the study insulin because they were not told what they were taking, and likelihood of incorporating into urine, again more with insulin Ipsitora. So the conclusions are, in type 2 diabetes, multiple daily participants, Ipsitora was non-inferior to Glargine glycemic efficacy. Ipsitora did not lead to increased risk of overall or nocturnal clinically significant or severe hypoglycemia. Ipsitora appeared safe and well tolerated based on participant retention and overall safety data. Then this was the final, what was given. This was given by Chettle Matthew, and she said, this is high time that we, is it the right time to start? Is it right time to switch to weekly insulin? So she gave a very good perspective, and these perspectives as regards to patients. So you need to keep giving me the once weekly, the patient, this was on an onwards trial with Icodec. She wanted to stay on a weekly insulin because she was having less pricks, and she was dejected when she was shifted to again to our daily regimen. But the provider perspectives are also very important. So endocrinologists always say there will be a major stacking of insulin and thus prolonged hypoglycemia impossible to manage. But these two trials onwards and Icodec and this our trial with Quint trial has shown that there is no stacking as regards to this, and the hypoglycemia rates was similar. Diabetes educated dietitians say with so much insulin on board, people will gain a lot of weight, but we have already seen that there was no significant change as compared to the basal insulin components. Primary care, oh, this is nice. But the general practitioner who is basically seeing more and more of patients, they feel that if you can give a comfort to a patient a weekly, so this will be a good idea. So this is about the onwards program. So again, this has been accepted in the Europe and Canada, but the US FDA has not given clearance because of this increased incidence of hypoglycemia in type 1 diabetes patients. So similar results, and with Quint, so this is an overview of all the 5 trials, and almost similar reduction in the A1C and level 2-3 hypoglycemia, lesser rates of interest. So this was a systematic analysis. So if you see the participants reaching glycemic goals without hypoglycemia, so more patients were able to achieve as compared to the basal insulins like Glargine. Numerically, more patients were able to achieve reach the glycemic goal of less than 7% without hypoglycemia. So we have now 2 options. The half-life of Icodec is 8 days and half-life of Ipsitora is 19 days. A more flatter profile, easy ways to start. So the first dose, if a patient is having 20 units of basal insulin, so you start, you have to give 7 times, and if you shift, and the first dose will be 1.5 times more, because that will be the loading dose, and thereafter you have to go for the dose that is taking into 7. And as regards to Ipsitora, this has to be 3 times because of the longer half-life for the loading the first dose, and thereafter you have to go for the 140 and titrate. So Icodec start with 70 units and Ipsitora start with 300 units, and from week 2 go for 100 units and titrate. So this was given by Rosentech. So it is easier way, start with 100 units at target. So stay with it. If no, go for 150 targets at 4 weeks, 8 weeks, 250 targets, 250. So you can keep on increasing. So this is what Dr. Jetau said, that it was a disruptive way of using basal insulin for clinicians. So concluding my talk, insulin continues to have a place in glucose lowering approach in many people with type 2 diabetes. Barrier to the timely use of insulin in type 2 diabetes exist. Once weekly insulins are efficacious and safe in people with type 2 diabetes and offer a solution for reducing barriers to insulin in type 2 diabetes. Way of choice of initiating basal insulin in people with type 2 diabetes with potential of disruptive novel ways of initiating and titrating dose, options for those already on basal insulin. So Dr. Chantal Matthew said, we meant yes, that weekly basal insulin is the in thing, and it is a paradigm shift into insulin basal treatment for type 2 diabetes. So these are the articles which have been published as regards to the Quint 1, Quint 3, and Quint 4 at Lancet. So thank you for patient hearing, and I'm open to questions.
Ajay, this was very good talk which you had given on once in a week insulin. And this is a future. Probably we are going to have our icodec also, maybe in another 3 months. So we all only question is that half-life of Efsitora is high. And why it is still once in a week? Can it be used once in 15 days? Or maybe more, maybe less? I mean, is there any possibility in future will they think of it? Except that they will be giving more injection. And was it giving less amount of hypoglycemia compared to icodec? Because icodec had shown slightly increase in risk of hypoglycemia. I was part of clinical trial for icodec, for type 1, for type 2. I have used in my clinic also the patient with icodec with continuous glucose monitoring. So in the Efsitora trial, have they used continuous glucose monitoring? And why they were comparing it with a glargine? Because that's why can't they use it with degludec? I mean, that's a better with longer half-life or I mean, these are, I know you have not created the trial design, not
Yes.
the one part of design, but I'm just asking.
So the first question is something like...
Yes, Manoj, you would want to.
Yes, sir, please go ahead.
No, so I think, thank you, Dr. Tiwari, for taking us through the entire Quint series. Exciting aspects. We at our center here in Mumbai have been part of one of those trials for Efsitora. Wow. Exciting. The only worry I have is with the entire world going the peptide way, I really don't know the future of these once weekly insulins, whether the intent for them is to get us the once weekly insulins or only look at combinations with the once weekly GLPs. So yes, we know the story with the icodec, which is stuck. And unless we really see the advantage of these ones in the type 1 and the pediatric population, which will take a longer time for approval, innovation is great, but it is still coming with some doubts there. Also, its own challenges for patients getting hospitalized, emergencies. We don't have any algorithms which have developed how to handle those who have already taken their dose and who may experience hypoglycemia or require hospitalization. So innovation must continue. I'm sure these once weekly will have their place in the therapy, but also come up with challenges right from understanding the dosing and misdosing. So 20 units increments is always going to be a challenge, more psychologically than the actual physical aspect.
So a question regarding this was asked there, that if someone has already injected a weekly basal insulin, so what will be the antidote for that? So the answer from Dr. Chatyu was that it is the glucose which will be the antidote for that. So that is basically in an emergency setting, you have to always go for...
will it mean that if patient is getting admitted for hypoglycemia, he will have to be for a longer period of time for this hypoglycemia?
Obviously, because you have to calibrate it accordingly.
But more problematic is, Ajay, suppose he's been admitted for some other emergency, and now you have to deal with the sugar control, or in between patient has been given steroid, and how will you now deal with a shorter acting because already insulin is on board? You are worried of hypo and hyperglycemia. So as Manoj has very rightly said, it's a long way to go. But yes, science will develop and we will get more and more such information. But we thought of that, during this meeting, we will keep few new topics, which are very exciting and very newer topics, which we normally don't discuss. And what we learned from ADA, I think we should discuss on our platform So now more and more doctors will also learn that these new things were there in American Diabetic Association. We are thanking ADA that, so much new things were there and we could discuss so many things. It's always good. We can invite Sanjay if we don't have any other question. Manoj?
Right. So, no, thanks, Dr. Tiwari, and that was great conversation. We now move to our final speaker for the day, Dr. Sanjay Agarwal, senior diabetologist from the city of Pune, secretary of RSSDI, uh, person behind the IDEC conference along with the team. Dr. Sanjay is going to be speaking to us today on the residual risk of cardiovascular disease in diabetes. Really, how do we evaluate that residual risk, and what do we do? Learnings from Chicago is what Dr. Sanjay Agarwal brings us. Over to you, Sanjay.
Thank you very much, Manoj. I'll just share my screen. Okay. Can you see my screen?
Yes.
Thank you. So thank you, Manoj, and thank you, Bansi, for giving me this opportunity to speak. This was a very interesting lecture. This was delivered by Dr. Mohammad Al-Safani, and he talked about, the residual risk and cardiovascular risk in people with diabetes and ACVD. And the reason why we really need to talk about residual risk is, let me sort of walk you through a case profile which will probably illustrate what we need to do. So this is a 62-year-old gentleman, his first visit to the diabetes center. Patient has diabetes and dyslipidemia for 12 years. He's had cardiac events, NSTEMI at 5 and 3 years ago, for which he had undergone primary angioplasty at the age of 59 and 57. He has hypertension. He walks 45 minutes. He's a non-smoker. And his current medications that he takes is rosuvastatin 40 milligram, ezetimibe 10, metformin, EMPA, semaglutide, aspirin, atenolol, and lisinopril. Now, if you look at his labs, his BMI and his clinical profile, his BMI is 24, not very bad. Blood pressure is 125 by 80, again not very bad, and A1C is 6.9. His lipid profile is very interesting. He's got a total cholesterol of 131, LDL of 48, HDL of 21, triglycerides of 205, and non-HDL of 110. So the question that really comes up is, why did he really have recurrent cardiovascular events? What do the guidelines recommend? And what are we really missing out on? Should we be more really aggressive? So if you look at this, it's not really a typical patient that comes to us and we say, okay, look, you have a fairly good demographics. But the question is that if your LDL goal is 48, then why is this patient getting recurrent cardiac events? That is the question that we really need to address. So let me look at the 2023 European Society of Cardiology recommendations of the LDL goal in type 2 diabetes. And if you look at the goals that LDL need to meet, then in very high risk patients, you need to have an LDL goal of less than 55. In high risk, it's less than 70. In moderate risk, it is less than 100. So, and you can see the class of recommendations. These are all 1A or 1B class recommendations. But if the LDL goals are met, then what is your next plan that you need to have? Clearly, you need to look at the non-HDL goals that the patient has got. So in patients with type 2 diabetes, where the LDL goal is met, the secondary goal of non-HDL of less than 85 in very high CV risk needs to be attained, or less than 100 in high CV risk patients is what is recommended. This is class 1B. Now, high dose icosapent ethyl, that's 2 grams twice a day, may be considered in combination with statin in patients who've got a hypertriglyceridemia. And this is 2B, level B recommendation. So patients who are at the LDL goal, which is met, you start looking at the non-HDL. And a high component of the non-HDL is the triglyceride value. And if you've got a high triglyceride, then there's clear evidence to show that you should use icosapent in these people to cause a triglyceride lowering. And let me sort of look at other societal recommendations. Now, this was a 2025 ADA standard of care where they looked at patients' LDL goal with type 2 diabetes, and this was more of a secondary prevention. So here patients have a lifestyle changes, high intensity statin therapy, and you aim for a LDL reduction of more than 50% to less than 55 milligram per deciliter. Now, if these goals are not met on maximum tolerated statin therapy, then clearly a combination with ezetimibe or PCSK9 should be done, which has a demonstrable effect. Alternate therapies that you can use is PCSK9 with monoclonal antibody, bempedoic acid, or with inclisiran. Now, if you have the LDL goals that are met, then what is next plan? And that's what even the ADA recommends in the 2025, that in patients with ASCVD or other severe risk factors on statin and managed LDL, but has a high elevated triglycerides between 150 to 499, then addition of icosapent ethyl may be considered to reduce a cardiovascular risk. Now, this is the ACE recommendation. So I'm just looking at across the board, what do really the societies recommend? And if you look at the ASCVD risk as a validated tool, and the patient is sort of your risk stratifying the patients, then if the individuals are without ASCVD, but has a high LDL, you can clearly, but not met by statin, then you can, there's nothing addition of PCSK9 or bempedoic acid in addition to usual care. But these are not recommended in these people. Now, if you've got individuals with ASCVD or at an increased risk for ASCVD, then you can add aliriximab or evolocumab in addition to usual care, condition recommended moderate certainty. Now, if you have insufficient evidence for use of inclisiran, so there's no sufficient evidence to use in these patients. And if the patient is statin intolerant, then you can use bempedoic acid in addition to usual care. Now, what about the individuals with hypertriglyceridemia, which is between 150 to 499 with ASCVD or at increased risk for ASCVD? They use EPA, that's icosapent ethyl acid, but they do not use a combination of EPA with DHA. So that is something that is not really recommended, right? And there is no recommendation of use of niacin in these people. There's still insufficient evidence of use of EPA or niacin in patients with severe hypertriglyceridemia of more than 500 milligram per deciliter. So if you look at, the LDL goal, which is the primary target that you want to look at patients with ASCVD, then you have to first target that before you look at other goals. Once you achieve the LDL goal, then you start looking at the residual risk of an individual patient. Now, if you look at all the therapies which are LDL based, they reduce but do not eliminate the cardiovascular risk. So look at the plethora of trials that 4SK, VOSCOPS, lipid, AFCAPS, HPS or PROSPER, all these sort of have great reduction to the tune of about 24 to 34% of cardiovascular events. But despite the LDL lowering, almost 60 to 80% have a residual risk that remains. So the residual risk of cardiovascular events persists despite current evidence-based medical therapy. And this is what you really need to look at, that how are you going to minimize the residual risk in an individual patient. Now let's look at the, other than LDL, the non-HDL components. You have chylomicrons, VLDL cholesterol, or intermediate density lipoproteins. These are all sort of triglyceride-rich lipoproteins or remnants. Then you've got LPA. So is there evidence to show that if you lower LPA, does it help? Then you've got LDL cholesterol. So should we aim for a much lower LDL cholesterol than what we really recommend? Or do we need to increase the HDL cholesterol? So this is the entire strategy that we really need to work out. And we need to answer these 4 questions. And there is evidence in trial-based data to show that, okay, should we aim for a lower LDL cholesterol? You've got the Odyssey, Fourier, Improve It, Inspired trials to look at this data. Do we need to increase HDL cholesterol? And you've got the AIM High or HPS2 Thrive trials. do we need to lower triglyceride-rich lipoproteins? And you've got to reduce it in the prominent trials to answer this question. Or do we need to lower the LPA? And you have the ongoing LPA Horizon trial or the Ocean 8 trials. So let's dive into these and see what does the evidence really show us. So let's first start that do you have evidence on reducing residual LDL risk? And here's the Odyssey Outcomes Secondary Prevention Trial, where they looked at 18,000 odd patients of more than or equal to 40 years of age. Patients had myocardial infarction, unstable angina for 12 months, already on high-dose statin therapy, where the LDL cholesterol was more than 70, non-HDL of more than or equal to 100, and ApoB of more than or equal to 80. These patients were randomized between aliriximab and placebo. Clearly, you can see the separation of the mean LDL value, where the aliriximab group had a lower LDL cholesterol by 54% at the end of endpoint than placebo. And in the placebo group, they actually had a 10% increase in the LDL cholesterol. So remember that this was on top of statin that the patient was already receiving. Now, if you look at the cardiovascular event rates in these patients who are on placebo or aliriximab on top of statin, then you have the events, cardiovascular events, where almost 15% occurred much less in the aliriximab group. And these secondary endpoints that you're really looking at is death from coronary heart disease, myocardial infarction, stroke, or unstable angina. The second trial that really talks about benefits is FOURIER trial. This is again a secondary prevention trial. They had about 27,000 patients, aged between 40 to 85. 81% of them had prior myocardial infarction. Patients were already on high-dose statin therapy, despite which the LDLs were more than equal to 70, and non-HDL was more than equal to 100. And these were randomized between placebo and evolocumab. Clearly, the LDL lowering occurred to almost about 54% at the endpoint relative to the placebo. And in the placebo, there was no reduction or slight increase in the LDL cholesterol while maintaining high-dose statin therapy. But look at the outcomes in the evolocumab group. There was similarly about 15% relative risk reduction in the cardiovascular outcomes. That's death from coronary heart disease, myocardial infarction, stroke, or unstable angina. So the benefit was there on top of statin to add evolocumab. So the FOURIER trial outcomes were clearly there that patients with diabetes, if you aim for an LDL of 30, then if you add evolocumab on top of that, even with an LDL of 30, will you get benefit? And there was clear separation that even at that lower LDL values in patients with diabetes, the events of cardiovascular death, myocardial infarction, or stroke still benefited. What about patients without diabetes and they had an LDL goal of 90? Then they had a benefit with evolocumab. But what we want to show is that low LDL and if you want to, we don't know what the lowest point of LDL goal should be, where the cardiovascular event rates really becomes negligibly beneficial. But at low LDL, add on evolocumab and you'll still get the benefit in terms of event rate reduction. So in a nutshell, that if you have with diabetes an LDL cholesterol of 30, you get far more benefit in patients without diabetes who have an LDL goal of 90. So there is a greater cardiovascular residual reduction in people with diabetes, even at lower LDL cholesterol values. Now, we need to look at the association of HDL cholesterol and cardiovascular disease. And this is a J-shaped curve where very low HDL had a high cardiovascular mortality, and extremely high HDL again had a high cardiovascular mortality. Now, this was a 17 prospective studies. They looked at almost 1 lakh and odd patients, and there were about 16,000 odd cardiovascular death. So did the people benefit by HDL increase is what we really need to look at. Now, when we talk about HDL, there is a whole debate on that should we really looking at quantity of HDL cholesterol level or functionality or quality of the HDL level, because it all depends on the unloading of the hepatocyte that tends to happen. The cholesterol gets released and then they sort of have a lipid-laden macrophage that tends to absorb all the cholesterol value. Now, this is again utilized for making the HDL cholesterol. So there is now a lot of data to show that HDL functionality is better than just looking at HDL cholesterol levels. And if you look at the efflux capacity, then it has a higher sort of benefit in terms of reducing the cardiovascular event rates. So what happens to the cardiovascular events when we attempt to increase the HDL? There are two trials that looked at it. One is the AIM-HIGH trial, and the other one was the HPS2 THRIVE trial outcomes. In the AIM-HIGH, there were about 3,400 patients. Patients had a cardiovascular disease and atherogenic dyslipidemia, and the patients were already on statin plus or minus ezetimibe. Now, add to this, patients were given an extended release niacin in comparison to placebo, and the primary endpoint was, of course, coronary heart disease, death, non-fatal MI, ischemic stroke, hospitalization for acute coronary events, or symptom-driven coronary or cerebral revascularization. The second trial was, of course, they again used an extended release niacin, that's lapropriant, when compared against placebo. These were 20,000 odd patients. Patients had an established cardiovascular disease, and the patients were already on statin plus or minus ezetimibe. The primary endpoint was cardiovascular death, non-fatal MI, stroke, or revascularization. So did really niacin help? In both the trials across the board, there was no benefit by niacin in trying to improve the HDL cholesterol values. So what happens when we try to improve HDL functionality? So we talked about HDL cholesterol. Now we're talking about HDL functionality. And they had an ApoAI infusion compared against placebo in about 18,000 odd patients, acute MI, and 90 days, right? Again, no significant difference in cardiovascular risk. These patients were already having myocardial infarction, stroke, or death for cardiovascular causes within 90 days. So clearly, there's no really benefit by increasing the HDL cholesterol, whether you use niacin, whether you use any, use an ApoA infusion, they really don't benefit by increasing either functionality or the HDL cholesterol levels. Now let's come to the third, addressing the third question is there a benefit on addressing the triglyceride risk? And this comes from the DAL outcome trials, where they looked at risk of cardiovascular disease increases with elevated fasting triglycerides in statin-treated patients, right? So you already have the LDL at goal. You are treating these patients with statin, and despite the residual risk, you're trying to get now the fasting triglyceride levels to benefit. And these patients were all treated, and clearly there's evidence to show that in different sort of quartiles or tertiles that we are really looking at, that across the different spectrum, there was clear reduction in the cardiovascular outcomes that you see. This was sort of also reiterated by the Copenhagen population study, where elevated ApoB and non-HDL better reflect residual risk in statin-treated patients. Now, these are all triglyceride-rich, and if you look at this forest plot, then addressing the triglyceride risk clearly reduce the occurrences of myocardial infarction event rates. So you can see the median values of ApoB, non-HDL, and LDL cholesterols. So if you have to now look at the risk profiling in non-HDL cholesterol, if you look at triglyceride-rich lipoprotein and remnants, you may reduce the LDL value, but if you've got a high non-HDL, plus ApoB that is increased, there's a 23% risk in mortality and 82% risk in myocardial infarction. And if you have only a non-HDL increase without ApoB, then there's about 18 to 21% risk of mortality and about 49 to 78% risk in myocardial infarction. Whereas if you look at all the LPA, LDL, HDL, if the LDL increases but you have a reduction in non-HDL and ApoB, then there is no risk in increase in mortality. So clearly there is a role to play for reduction of non-HDL and ApoB, because increase in this increases mortality and occurrences of myocardial infarction. So triglyceride-rich lipoproteins contribute to the residual cardiovascular risk in statin-treated patients who are on managed LDL cholesterol values. Now, what happens to the cardiovascular events when we attempt to reduce the triglycerides? And here's a host of trials which looked at triglyceride lowering with different agents. And you've got, Omega, Origin, Risk and Prevention, Vital, Ascend, Omni, I, Strength. All these had EPA and DHA mixtures. And then you've got the field trial with fenofibrate, Accord with, again, fenofibrate, AIM high with niacin, and prominent with pemafigrate. If you address this, there was no significant reduction in the cardiovascular disease rates. But the same thing when you use a purified EPA, this was in GELIS, REDUCE-IT, and respective EPA trials, there was a significant reduction in the cardiovascular event rates, although there were numerically lower CVD event rates. So there is a benefit when you use purified EPAs. Now, what happens to the if you look at the REDUCE-IT trial, IT trial, these were about 8,000 odd patients with established cardiovascular disease or type 2 diabetes with cardiovascular risk factors, patients already on statin therapy and triglyceride values of between 135 and 499. They looked at the endpoints of CV death, non-fatal MI, non-fatal stroke, coronary revascularization, or unstable angina. These patients were given icosapent ethyl on top of statin therapy, and clearly there was almost about a good 23% residual risk reduction, or almost about 25% residual risk reduction when icosapent ethyl was added on top of statin therapy. If you look at this, this meta-analysis, this sub-analysis on the forest plot, so in the secondary prevention cohort, there was benefit with using icosapent as compared to primary prevention. Whether the patient had diabetes at baseline or no diabetes at baseline, again, there was clear benefit with icosapent. And if you look at all the different goals of LDL, less than 67 or 67 to 84 or more than 84, on top of statin, icosapent benefited in terms of reduction of the event rates. Now, what happens when we attempt to reduce triglycerides? And this comes again from the REDUCE IT trial. This was analysis of subsequent cardiovascular event rates. And you can see that not only the first subsequent event rate, but all subsequent event rates also benefit. And here's the data that showed that when compared with placebo, icosapent, whether it's first event, second event, third event, fourth event, or more, all these subsequent event rates tend to reduce with the addition of icosapent. So what do we know about LPA? Now, if you look at the LPA, there is clear association of LPA with cardiovascular risk, occurrence of aortic stenosis, and stroke risk. And this is now becoming more and more focused that should you really look at LPA and how atherogenic this is as compared to the LDL cholesterol. There isn't much data to show that, what can we do and what are the good therapies for, reduction of LPA. So statin therapy, you raise, it doesn't cause really much of a change. Niacin, it may lower by 15 to 20%. Bempedoic is low neutral. PCSK9 lower by 25%. Lipoprotein epheresis lower by 50 to 70. But we are waiting for two good trials at the horizon with peclaserin and Ocean A outcomes with olpasiran trials, which are really looking at does LPA lowering really help. Now, one of the things that really got discussed is that if you're looking at LDL goals, right, and you have an LPA that is elevated, then how do you really interpret this? So one of the things that really came out in the discussion was that if you have an increase in the LPA values, then you perhaps need to further reduce the LDL goals because to factor in the high LPA values. So if you're looking at 70, then you probably need to go down to 50. And if you're looking at 50, then you need to go down to 30 if you have an elevated LPA values, given the fact that we don't have good therapies as of now to reduce the LPA values. So let me sort of sum it up for you that Should we aim for a lower LDL values? The trials have been great in showing that people with diabetes have greater residual cardiovascular risk, even with LDL of less than 30. So there is something other than LDL that really drives this residual risk. Do we need to increase HDL? So attempts to increase HDL did not really reduce the cardiovascular events. And attempts to increase the HDL cholesterol efflux capacity did not significantly reduce the MACE at 90 days. Do we need to lower the triglyceride-rich lipoproteins? Then addition of EPA to statin and a group of patients who have diabetes and triglycerides between 135 to 499, they showed a further reduction in the residual cardiovascular risk. And do we need to lower the LPA values? It's a rapidly evolving concept, promising, but we don't have enough data about it. So I'll end up my talk by saying that despite the success of LDL lowering therapies in reducing cardiovascular risk, people with diabetes who have well-controlled LDL goals still have a residual cardiovascular risk. Lipid management does not stop when LDL cholesterol is at goal in people with diabetes. The use of purified EPA in patients with ASCVD, LDL within target, and elevated triglycerides above 150 is associated with a reduction in cardiovascular events. And HDL function matters more than HDL cholesterol, but interventions to improve HDL functionality are promising, but we don't have enough data about it. An intervention that selectively lower LPA shows promise, but then again, there are ongoing trials which are eagerly awaited. We don't know the outcomes as yet. Thank you very much for your patient listening. Any questions? I'll be very happy. I don't think there's anybody on the platform. So, oh, okay. Amit
Yes, thank you,
Hi.
Sanjay sir, for once again a very excellent presentation, and you have summed it up so nicely, starting right from the LDL cholesterol and talking about the other components, including the up to the little LPA. So now my question is that now learning from the ADA updates, the message is that we need to aggressively address the lipid risk by addressing the different components. Maximum statin therapy, then role of ezetimibe, and then the role of the PCSK9 inhibitors. So my question to you is, with the current availability of the PCSK9 inhibitors like inclisiran in India as well. So as a clinician, what are the key considerations before we start any patient on the inclisiran or some molecules like that? So there's because these therapies are needed, long-term therapies. You need injections initially maybe twice a year, then once a year. So how should a clinician approach to therapies like this?
I think that's a great question, Amit. What I do in clinical practice, okay, let's talk about that. Now, if the patient comes to us with a very high ASCVD risk, right? You have patients with diabetes, recurrent cardiovascular events. You've already achieved with statins the maximum LDL goals, or if you've got the maximum tolerated statin and you've still not achieved the LDL goal, then there is clear evidence that we need to add an additional drug so that you aim for an LDL goal of 50. Now, having said that, if you've achieved an LDL goal of 50 and yet you haven't achieved and the patient still continues to have a high ASCVD risk or residual risk that the patient has got, and if the triglyceride values are more than 150 to up to 499, you need to address that triglycerides. Very often, we really don't look at the triglycerides, right? So on one end, you've got, let's say, statin, high dose statins is getting into the LDL. You've got the next subgroup of patients whether you've got a high dose of statin, you've reached a tolerability point, but you still haven't achieved the LDL goal. So your first intent would be get to the LDL goal. Now you may add a PCSK9, you may add inclisiran, whatever you like, so that you achieve an LDL goal. Now, once you've achieved the LDL goal, you look at the non-HDL value and you look at the triglycerides, right? And you need to look at a non-HDL goal of less than 85, and you have to bring down the triglyceride values, which if it is between 150 to 499. We've got great evidence to show that in the non-HDL, the triglycerides are the most important component that you're really looking at. So if you bring down the triglycerides, then very likely you'll be able to bring down even the non-HDL goals in these patients. And the icosapent pent has really shown great evidence in terms of triglyceride lowering. So on top of statin therapy, when you look at this, then the patients get far more benefit. And you've got evidence out there when you've got patients on statin, they've looked at plus or minus ezetimibe and add on to that icosapent, and you've got further reduction even at low LDL values of 30 and below, that if you add a triglyceride lowering, then the benefit continues to happen. So I think it's all about addressing individual goals that you're really looking at. There is no evidence to show that LPA lowering helps as of now, unless the trial evidence comes in. There is still no strong evidence to show that if you increase HDL, does it really have benefit? Whether you're looking at absolute values or functionality of HDL, we really don't know whether that really helps or not. So you'll end up sort of having that only LDL goals meet them and meet your triglyceride goals and see how best you can address the ASCVD risk.
Excellent summary of your talk, which you have given in just this one statement. And Dr. Ajay Tiwari, your talk was really covering the FCTORA really well, and all the Quint trials and once weekly insulin therapy, showing the entire landscape. So are there any questions? If there are any questions.
Amit, I just want to make one comment.
Yes, please.
So one is, Sanjay, wonderful talk. And why we kept is, the residual risk. In India, mostly what we see, the primary care physician, they even stop LDL when it goes less than 100 or even 80. Or sometimes they try to decrease. Even with 5 milligram medication of statin is available, they don't think of that what they should do further to decrease it. And as you had said that even it goes up to 30 and 50 and still they have the residual risk. And primary goal is to reduce the LDL. And if at that point of time you can think of reducing the triglyceride, it will further add to decrease the cardiovascular mortality. So this can be a message to primary care physician across the country that LDL lowering and for the residual risk, they should continue to chase the lipids and try to keep with very high risk population at least less than 50. It's not the target, that just less than 100 or less than 70. That's very important. And we really enjoyed all three talks. It was really good. Yes.
Perfect point, Banshi. My question to great talk on the residual risk. Sanjay, HDL, what do we do about it? So do you really think if you're getting the LDL down, very often you see if you're being aggressive with LDL, the HDL further drops down. Now, even otherwise, low HDL is itself an independent risk factor. What do you really do about it? Does it matter? Do we bother about it? We let it be.
So as of now, as I showed in my slides, what we really need to look at, is it the functionality that matters or is it the absolute value that really matters? Now, either ways, we don't have strong evidence that if you increase the HDL, does it really improve the cardiovascular outcomes. And I've shown the trial data. We'll have to wait for more data to come in.
Bansi sir, can you please mute yourself? Yeah.
Okay. So, we don't have real good trial data to show that does HDL cholesterol improvement, does it really bring down the cardiovascular event rates, and what level do you need to take it up to? I agree that there is a strong risk factor with low HDL that we keep talking in all our talks, but we don't have, number one, of course, good drugs to show that how they've looked at all the other drugs. There is some benefit with, high intensity statins that it may improve the HDL, but then that's again HDL numbers that really improve. It's not the functionality that really improves out there. So I think we'll have to wait and see till we get more trial data to show that does HDL increase really help or not.
And what about lipoprotein small as that should guide in lipid lowering, we should be based on the lipoprotein A levels.
So LPA levels as of now, again, I showed as in the last slide, we don't have, there's still ongoing trials about it. But what we really look at is that patients who've got a high LPA, right? You need to lower your LDL targets even more in high LPAs. So let's say if your target goal is really, you're looking at 50, all right, as a goal. But if you have a high LPA, then you should lower by another 10 or 10% or 20% your LDL goes further in terms of endpoints that you need to look at. So as of now, that data is clear that with a high LPA, lower your LDL goals further. But we don't have any trial data to show or any drugs as of now that how you're going to do a direct reduction of the LPA values.
So thank you, Manoj sir, for asking those questions. And Sanjay sir, there are a couple of questions from our viewers in the chat box. And one of the question is regarding are we falling in the trap of PCSK9 advocacy lobby, which may not be good for the Indians with unique lipid profiles. And at the same comment, there is another comment that with better control of the glycemia with very effective antidiabetic drugs, we may also achieve better TG values too. So what is your opinion on this?
I think I'll take the second question first, because I think it never takes away the fact that you need to have good control of blood glucose. And I completely agree with you that once you get good control of glucose, then there is a reduction in the triglyceride values. What we are really talking about, assuming the fact that patients have got a good control of blood glucose, but I agree with you that if you have a poor control of glucose, then your focus should be getting your glucose control improvement, whichever way you look at it. And on top of that, of course, look at aggressive triglyceride lowering once you've got your blood glucose in target, right? So I agree with you on that point completely. Your second point, that are we falling in the trap of PCSK9 advocacy lobby? There is evidence to show that, high LDL is directly correlated to cardiovascular outcomes, right? And patients who've got a very high risk or a high risk and not achieving the LDL goals despite being on maximum statin therapy, your next step will have to be to show that how can you lower the LDL goal. And these patients, the evidence is either you can add bempedoic acid, you can add ezetimibe as a first-line treatment. Having failed to achieve the goals with ezetimibe or bempedoic acid, and there is good trials to show a combination of statin with bempedoic acid and the reduction in cardiovascular outcomes, right? But if you still don't achieve your LDL goals, despite the addition of this, then the only way to go is to go with the PCSK9 or inclisiran, because absolute values of LDL reduction really matter in terms of outcomes.
Right.
Now,
yes, sir, please carry on.
Yeah.
Okay. Sir, thank you for your comments. I would like to make it more simple for our audience by stating that, see, we are looking at the development of the science, and there is a lot of evidence with the PCSK9 inhibitors now. So we cannot simply overlook that, and we cannot simply overlook and say that this is about lobbying. So I believe PCSK9 inhibitors, they have a role. But in India, we are still struggling with controlling LDL with the maximum statin dose. So most of the time, most of our prescriptions, they do not have high intensity statin even when it is required. So I think there is a lot of unmet need in terms of statin therapy in India. And the first step to reach towards using any PCSK9 inhibitor, there is a rider on that. You have to first give maximal tolerated doses of the statin. So if you are giving 5 milligram of statin and thinking about the PCSK9 inhibitor, then it is not the message which this platform wants to give. The message is very, very clear. You follow the trials, you follow the guidelines which are there, and they very clearly talk about using statin first, using statin in maximum tolerated doses, intensifying statin, achieving target LDL goal, especially in those with established atherosclerotic cardiovascular disease, more than 50% reduction, less than 55 LDL, which I believe if we still scroll through our records, it will be, it is easier said than done. So here comes the role of other drugs, like PCSK9 inhibitors. So definitely, your question is very, very valid, but at the same time, we need to look at the science. This is how I will answer that. And sir, there is another question. I think I was wondering why nobody has asked that. We are very fond of using saroglitazole in our patients, and we call it one of the Indian innovation. And we also know that we use it in like Messeld as well. In India, it has found a use in Messeld. So what is the role of this saroglitazole in managing triglycerides as of now?
Yeah, I think you have a point there that, okay, saroglitazars do cause triglyceride reduction. The problem is that you've got a lot of data of saroglitazar with mast cell and with, fibrosis. As of now, we don't have long-term high good quality data on cardiovascular risk reduction. That's the problem right now, that does saroglitazar really cause benefit in terms of cardiovascular outcomes? Well, there is data in terms of MASLD that I think clearly that piece is really established. So we'll have to wait till we get some cardiovascular outcome trials with saroglitazar to say that does it really benefit or not. So I think that the field is open right now. You can certainly use it for triglyceride lowering, and if you have no other choice, but the data is more stronger with the icosapent. I think that's a purified icosapent that is really that's more convincing as of now till the saroglitazar CV outcome trials really come out. And
So
I completely agree with Amit when he says that, we don't push our patients to the maximum statin limit. We still continue to use low dose statin therapy and expect the benefit, whereas the trials have gone up to 40 and 80 milligrams. So we don't really push our patients to those levels. Of course, keep in mind that we need to keep monitoring the muscle health of people because rhabdomyolysis and all these things are possible, but they happen in a very small fraction of people. It's not the rule that happens, and you need to keep monitoring. If patients do complain of muscle aches and pains, then you should be quickly to reduce or stop the drug to allow the to prevent rhabdomyolysis from happening.
And sir, last question. Do we have purified EPA here?
Yes, we do have. I think it's available in the market. Yes.
So with this, Dr. Sanjay Agarwal, sir, thank you very much for an excellent deliberation. Dr. Ajay Tiwari, I'm again very grateful and thankful to you for your talk. And I can see our secretary, our Diabetes India, Dr. Bansi Sabu. So I would request him to make final comments.
I'd say wonderful, first of all. Just to tell you today, to thank Torrent for they could message almost more than 25,000 participants. And I mean the delegates, but today we were having 2,500 plus delegates who were registered for this meeting. To start with, we were having 700 plus doctors who logged in. And in between, it has increased up to 900 doctors. And again, today, now maybe around 700 doctors are still there. So I'm thanking everyone and who is, present till 10, 15 or 10 p.m. in late in evening. I'm thanking all of them. Big thanks to all three eminent speakers, Dr. Sanjay Gawal, a wonderful talk. Ajay Tiwari, very nicely covered, a very new topic, and you had covered almost every aspect of once in a week insulin. And thanks to Shashank for his wonderful deliberation. Thanks, Manoj, for chairing the session. And thanks, Amit, as a Joint Secretary of Diabetes India and chairperson for this wonderful event. With this, I thank everyone. And thanks to RX Event and Torrent for this, giving us the platform for Diabetes India platform. Anybody wants to make?
Thank you.
Yes,
Thank you for the opportunity and thank you all the speakers and thanks for all keeping us academically busy.
Thank you, everyone. And I
Thank
Thank
hope
you,
you,
to
Bansi
see
Bansi.
sir.
you
Thank
all
you,
Thank you,
Manoj.
Amit.
Thank
tomorrow.
you,
Thank you,
Amit.
Sanjay sir.
Do
Manoj
join us tomorrow
sir.
again.
Bye bye,
Good
Dr.
night.
Ajoy. Good to see you.
More
Great
topics.
talk, Sanjay. Shashank.
Tomorrow again, the same time. Manoj, don't
Yes, sir.
forget.
Right.
Yes, sir.
Tomorrow also, I will share only Banshi. Do I have to speak? Okay. Okay.
Okay,
Bye.
bye bye. Good night.
Okay, good night, sir.